and I have the honour of kicking off. Okay, it's interesting. I can see quite a few people from my own unit there, and they're probably wondering, why is this guy being asked to measure, to talk about measuring cardiac output in the septic patient? Because we hardly ever do it in our own unit. And I think it's fair to say that we've sort of gone through a period over 10 years of almost going full circle from being quite non-invasive to very highly invasive and aggressive, and we're sort of now moving back into a phase of measuring less and less. Now, I don't necessarily think that that's a good or a bad thing, and I'm not neither pro nor anti-measuring cardiac output, but I think it's vital that we think about some of the issues behind why we do it and when we do it. So when I was thinking about this talk, I guess one of the things I didn't really want to do was give you a long list of the technologies that are available today, because there are actually numerous technologies and they all have their pros and cons. But if you are interested, I will be talking a bit more about that and some of the measures of components of cardiac output later on this afternoon at 5 o'clock. But I think a really crucial point to start, particularly in the septic patient, is more to think about not so much the how, but the why and the when, and what are you actually asking. So let's just bring this right back to basics. Excuse me. Why should we think about advanced hemodynamic monitoring? And I'm not talking just about cardiac output measurement here, but all forms of advanced hemodynamic monitoring in the septic patient. Well, there are at least 4 reasons. The heart commonly fails in sepsis. When the heart fails, it tends to happen reasonably early in the process, and it's one of the most common causes of death in sepsis. And most or many of the therapies that we actually give to try and normalise hemodynamic parameters may actually have an adverse effect on cardiac function. And we can't estimate this effect clinically. So I'll talk about these in a little bit more detail. This is a study that's really stood the test of time. It's 10 years old now, but it's from Joe Carcillo's group in Pittsburgh. And they looked at really the hemodynamic profiles of a group of 50 children in septic shock. And these were all children who had been resuscitated aggressively and early with at least 60 mils per kilo of fluid resuscitation. And they all had a PA catheter inserted relatively early in the course of their illness. About 1/5 had meningococcal disease, and the rest were a mixed bag, really, of immunosuppressed, non-immunosuppressed, bacterial, fungal, viral, etc. Now, there were several very key messages from this study. If we think about what we know about adult sepsis, the typical hemodynamic profile is the heart that dilates up but manages to maintain a reasonable cardiac output. So the heart dilates, you decrease your fractional shortening, but because you've dilated, you've actually got reasonable forward flow. And the other key thing about adult sepsis is that vascular failure is very common. So the commonest hemodynamic profile is the high cardiac output, low SVRI. And interestingly, what the Pittsburgh group found was that the exact opposite happens in pediatrics. You can see the most common profile is actually the opposite, low cardiac output and high SVRI. And then the other 2 profiles, which were equally split, was the adult type profile of the vascular failure but preserved cardiac function. And lastly, where both are actually going awry, so low cardiac output and low SVRI. The other important point from the study was that the mortality was different in these 3 profiles. So the commonest hemodynamic profile also carried the highest mortality. And they also found that when you measured these things, the temptation was to do something about it. So most of these patients had a change in therapy, the vast majority of them, over 90% in most groups. But the other important point is that when you followed what happened to the hemodynamic profile over time, it changed drastically. So if you started at point A with one particular profile, there was no guarantee that 12, 24, 48 hours later you would be in the same sort of profile. So these children cross groups. And, for example, you can see that the sort of adult-type cardiac failure, about half of these patients actually eventually required inotropes. Second point is myocardial failure is a common cause of death in sepsis. And these are some data from our own institution, going back a few years now, but looking purely at patients with meningococcal disease. In many ways, that's the sort of cleanest form of sepsis because you're dealing with well protoplasm, the well child who was well 1 minute and then has overwhelming gram-negative mediated sepsis the next. And you can see that if we break down the deaths temporally, that the majority of the deaths are occurring before we actually get to the ICU or just soon after we get to the ICU. And these patients are referred early. They're referred as soon as they're coming through the door from a group of district general hospitals within a 60-kilometre radius around other hospitals. And the median time from referral to getting these patients back to the hospital is about 2 to 3 hours. And you can see that's quite different from any of you that were here in the morning slide, which showed some of the data from Mexico, that these children waited on average 15 hours in the emergency department. So it's a slightly different population. But the take-home message here is, by far, the majority of deaths occurred early. And if you survived the 24 hours, you were probably going to survive. Actually, the other point I would make is that our accrued death rate, if you take into account deaths before the team arrives or early on after arrival, is 8%. If you take away those deaths, as other institutions have done, you will get a 2.5% mortality, but it's artifactual. Well, what do we do? What's the most common thing we treat in sepsis? I think the bottom line for all of us is hypotension. It's the one thing that we don't tolerate. Okay, thanks. And many of the therapies which we actually use may adversely affect cardiac function. And these two cartoons really are based on data from 2 real patients, but I've standardized the data so you get a feel for what it actually means. What do we do when the blood pressure's low? Well, the first thing we often do is give more fluid. And you can see in the top cartoon that the Starling relationship, which we're all familiar with, is not a straight line. It plateaus off, and if you continue to overfill, you'll actually overstretch the heart and make cardiac function worse. So what have you done to this patient? They've got a very narrow pulse pressure, which is a sign maybe the cardiac output's poor. They've got a reasonable mean, but it's not great. CVP is low, perfusion pressure is this, and this is the cardiac index. When you overfill, you reduce stroke volume, and this is what happens. You've actually improved the blood pressure, but what have you done to the cardiac function? You've made it worse. And what have you done to the perfusion pressure? You've also made it worse. So that's one scenario. The second is we use inotropes, and many of our inotropes are actually inoconstrictors, so dopamine, adrenaline, noradrenaline, probably 3 of the commonest. And when things are going bad, we tend to jack the dose up, because what else can you do? Again, that has a downside. There is an inverse relationship between contractility and afterload. Okay? So the more you increase contractility, the price you pay is a reduction in afterload. And in sepsis, that relationship changes. This curve moves down, and the slope becomes more steep. So for a given same increase in afterload, you're starting at a lower cardiac function or lower contractility, and the decrement in contractility is more. Okay? Same sort of thing. Exactly the same hemodynamics. What have we done? We've improved the pressure, but we've made the cardiac output worse by 30%. Okay? And we don't know that we're doing this unless we measure these things. We can't estimate these changes clinically, and there are numerous papers in adults from the 80s and early 90s showing this, and there are at least 2 that I'm aware of in Pediatrics where we've asked clinicians to try and estimate cardiac index, and we can't. But I think this is demonstrated nicely from the older study, which is from Mercier's group in France from the mid-80s. And if you look at the hemodynamic profiles of children with meningococcal sepsis, this was 18 patients, and you follow them, non-survivors and survivors, there's no difference in blood pressure in the group as a whole. But what is different is the non-survivors have a consistently lower cardiac output. So the next thing that usually gets thrown up at you is, but measuring cardiac output doesn't improve outcome. And I would kind of agree with that, but I think we need to think about why. This is one of the latest studies which have shown that, in adult medicine anyway. I mean, there's never been a pediatric RCT which has shown that. But this was the PAC-MAN trial, a multi-centre trial based in the UK. And essentially they showed no difference between PA catheter use and non-PA catheter use. What I would say is this wasn't cardiac output measurement versus no cardiac output measurement, because 70% of the control patients had a less invasive form of cardiac output monitoring. So this was probably comparing not like with like. What we really have to think about is what have all these studies actually been testing when they say cardiac output doesn't make a difference? The first thing is most of them, without fail, have been unstructured with respect to what happens after you measure cardiac output. So you measure it and then you just do what you like, basically. So what are they measuring? Are they testing whether the measurement of cardiac output per se is bad? Or are they testing the particular tool that we use to measure cardiac output? So that was the PAC-MAN, for example, PA catheter versus Doppler or whatever. Or are they testing how we actually interpret and act upon the information, or is it all three? And I think it's probably all three. And what we haven't yet done is tested whether a cardiac output measurement can actually provide benefit when it's incorporated into a sensible goal-directed therapy algorithm. Okay. There are a couple of instances in adult medicine. I mean, probably the most familiar with all of you would be Hayes' study from the mid-90s, where they looked at looking at supranormal levels of oxygen delivery, and they found if you did that, it was worse. I think what they were testing there was a flawed concept, which was demonstrated quite nicely in the study. And there have been several studies in adults looking at perioperative optimization using transesophageal Doppler, so optimizing fluid. And that does actually show benefit. Just to sort of illustrate the point about the goal-directed therapy, I mean, you've probably seen Rivers and numerous talks in this meeting and every other meeting you've been to for the last 5 years, but I just want to make one point about the Rivers study. This wasn't measuring cardiac output, but it was incorporating central venous saturation into a very tight algorithm for goal-directed therapy. And the important take-home message with this study is the patients did better when they had their central venous saturation measured, but they did better for this reason. They didn't get more fluid over the 72 hours, but they did get their fluid early. Okay, so they were aggressive. They didn't get more inotropes, but they got the inotropes instituted earlier. Okay, and the patients who needed mechanical ventilation in the goal-directed therapy group all received their ventilation within the first 6 hours. So, but in the non-goal-directed therapy group, another 20% of the patients deteriorated and needed subsequent ventilation. In the goal-directed therapy group, they didn't. So that highlighted the importance of incorporating whatever monitoring tool you're using into the proper algorithm. So, are we testing the measurement of cardiac output, say, or actually are we testing the tools? So let's focus on the tools that we use now. Okay. When we think about whatever tool we choose to use, and there are many now, I think it is absolutely vital that we have an adequate knowledge of the technique. If we treat whatever tool we're using as a black box, you won't understand what the numbers mean, but perhaps more importantly, you won't understand when you are operating in circumstances that may affect the accuracy of that tool. Now, even if you optimize things and you minimize the accuracy, every tool has a variability that's inherent in the tool, and that is a very important point. And I think it's something we don't really pick up on. One of the things I look at when I look at a study with a new tool is what the coefficient of variation is. Okay, because if that's high, forget it. Do we know what we're measuring? Again, if you've ever seen me do this talk before, apologies for this repeated slide, but I think these are two very important studies because they demonstrate this beautifully. These were two adult intensive care-based studies, the first in in the United States, and the second in Europe. And they were 7 years apart, and they were almost identical. And it was basically a snapshot of clinicians' knowledge. They asked 500 clinicians, or thereabouts, in centres throughout Europe and North America, how much they knew about the pulmonary artery catheter and what they do with the information they glean. So it was a questionnaire, basically. And there was recurring themes that were almost identical from the two studies. Now, remember, at this stage, the PA catheter had been in use for almost 20 years in adult medicine, so it was kind of the standard of care. That was in its height of use, really, the sort of early to mid-90s. And what they found is that your knowledge of the pulmonary artery catheter, certainly in the Aberti study, was better the more you used it. So it raises the point, if you're going to measure cardiac output, if you're going to get good at it, you probably have to do it quite a lot. And that's sort of a catch-22 situation, because do you actually need to measure it on everyone? So, somewhere in there might be a happy medium. I don't know what it is. They also found that people were better the more senior they were. And lastly, hospitals that had a medical school affiliation, so teaching hospitals. Now, the second study, same sort of thing. These findings, they also found that people's own impression of their knowledge was reasonably accurate. So if you thought you were quite good at interpreting the data, you were reasonably quite good. And you were better if you had the role of supervision. So that again raises the point of, you need to sort of put it in a lot and supervise others doing it. And again, the same thing at med school. But two things sort of glare out at you, just to highlight how bad we are at our knowledge. Wedge pressure was the sort of gold standard for left ventricular preload, if you like. But 50% of respondents from both studies could not accurately identify wedge pressure to within plus or minus 5 centimetres, okay, when they were showing the picture. So you were showing the PA catheter, and then you wedged, and then you did the end expiration, and where do you measure your wedge and what is it? And over half of the respondents could not recognise a picture that showed sighting a waveform of sighting the PA catheter inadvertently into the systemic artery, into the aorta. Okay? A bit worrying. Now, all of these tools that we use, so the dilution techniques, of which there are at least 3, the FIC techniques, which there are multiple, but generally speaking, FIC, indirect and indirect, and the Doppler-based techniques, and bioimpedance to a lesser extent, all have a degree of variability, and there are circumstances when they are suboptimal, and I will talk about those more this afternoon. But I'd like to just focus now on the inherent variability in the tool itself. Statisticians, when they talk about accuracy, will talk about the mean squared error. And the mean squared error is a combination of the square of the bias and the square of the precision. Precision is another name for standard deviation, so that squared is obviously the variance. And these are 2 theoretical tools for cardiac output measurement, method X and Y. And you can see that method X, if we have a hypothetical true cardiac output of 4.5 litres per minute per metre squared, has a positive bias, so it tends to overread. But it's relatively high precision. If you repeat measurements, there's not a lot of scatter. Technique B has a good bias. It's almost a perfect cardiac output, but it has a much higher scatter. Okay? So if I had a choice as to which one I would take, what would that be? Well, let's, again, hypothetically change the cardiac output from 4.5 down to 3 litres per minute. You can see that tool A, you generally get the impression if you measure here and measure here, you'll pick up that the cardiac output has decreased. Tool B, although the bias is okay, you can feasibly see that you may make 2 measurements and you may interpret the cardiac output as going in the wrong direction, the opposite direction to what's actually happening. Now, this is a demonstration of what a sad person I have and what a sad life I have. But I ran a simulation study on 3,000 cardiac output measurements in my spare time. Well, it was either that or watch an episode of EastEnders that night, so maybe I'm not that sad. And this is what happens. If you imagine a situation where the cardiac output drops by 25%, okay? So you start with a cardiac output of 3 and you go down to 2.25. So a significant, I think most of us would agree that a 25% drop is significant. And then you simulate those measurements on a highly variable tool, which has a mean bias of 0. So it's spot accurate in terms of the average cardiac output, but the coefficient of variation is 20%. The coefficient of variation is the standard deviation divided by the mean, expressed as a percentage. And you can see the pre-measurements are here in red and the post in black, and there is a huge overlap, okay, between those two, an enormous overlap, so you're not going to pick it up. And what most people would suggest with the PA catheter, for example, is to take the triplicate of 3 measurements. So if you do that, you still get an overlap, albeit a much smaller overlap. But there are still a significant amount of times when you'll actually not change the cardiac output or interpret it as increasing. If you take another tool which has a much lower coefficient of variation, like, say, for example, the PICO, or transesophageal Doppler, their coefficient of variation is down about 5%. Sorry, I should say the PA catheter in ideal hands is somewhere between 10 and 15%. In reality, it's probably closer to 20, so that's sort of the PA catheter. This is the sort of PICO, Doppler, a few other techniques, where the coefficient of variation is 5%. There's much less overlap, and again, if you do triplicate measurements, there's almost no overlap. So I think that sort of illustrates the point. And the same thing, sorry, just to hammer the message home, when you repeat the measurements, when you do paired measurements, how do the paired measurements change? Well, again, with these high variability tools, on average, you'll see that they decrease by 0.75. But on at least 15% of the occasions, you'll actually interpret it as an increase if you do single measurements. If you triplicate, there's still 5% of the time you'll actually interpret it as an increase. And that's nothing new. Stats showed that in 1982, so I'm really just repeating his work. So how do we interpret the information? This sort of highlights the point that if you're a very protocol-driven unit, you will function as well as what your protocols are. And this was a study from a colleague of ours, Duncan Winkle, actually, who's one of the adult intensivists at Guy's and St Thomas's. And they looked at 2 adult ICUs in South London who looked after patients after aortic aneurysm repair, and they had the same surgeons operating, so that there was no surgical variation. But one hospital was very protocol-driven and had a almost ubiquitous use of the PA catheter, and the second hospital didn't, tended to go more on indirect parameters of flow. And combined with this, they were very protocol-driven. If the wedge is below this, you give some fluid. If the cardiac output's below this, you give a inotrope, etc. And you can see the outcome's quite different. They use a lot more fluid in this unit. Okay, they use more inotropes, have a higher incidence of renal failure, and they have a higher mortality. So maybe the patients are sicker, I don't know, but certainly the Apache scores weren't different. The other thing is when we're thinking about cardiac output, by itself it's a meaningless figure. What we need to think about is that cardiac output adequate for that patient at that point in time? And that brings in the whole question of where does cardiac output fit into the sort of wider milieu, therapeutic milieu? I mean, where does it fit into the role of the balance between oxygen consumption and oxygen delivery? And just to confuse things even further, there's this concept of dysoxia. So you can manipulate this and that, but you may be doing nothing if the cells can't uptake oxygen. And we also need to think about the parameters that make up cardiac output. So this is what we do in the current scheme of things. Okay, there are very few things we actually commonly measure. Obviously, hemoglobin concentration and oxygen saturation we measure as a given. We measure heart rate and blood pressure. Most of these other things we don't actually measure, so we're missing a lot of pieces of the puzzle. But that's a two-sided coin, because you can say the more you measure, the more you can get wrong. If we measure cardiac output, it's another piece, but what's going on here if we decide it's inadequate? All these factors, I mean, if you look at a physiology textbook from the 70s or the 80s, they will call these independent parameters that affect cardiac output. But what we now know for the last 15 years is that they're interrelated. So you may have a defect in preload, which is increasing your afterload, which is adversely affecting your contractility. And what's the root cause there? So it's a very difficult thing to sort out. And in fact, that diagram can be expanded because you can think about all of the factors which actually influence preload, contractility, afterload, etc. So it's a lot more complex than I think we often think about. So what do we actually do in real life? Well, we interpret the information using a mixture of clinical parameters, and if these are of a particular type, so the weak thready pulse, the low pulse pressure, the prolonged capillary refill, the low urine output, we'll call this low cardiac output syndrome. So that's a fairly nebulous concept. And we combine that with markers of adequacy of flow. Again, continuing on my negative theme, these have all got downsides, okay? To understand a mixed venous, or in fact a central venous is what we usually use in clinical practice, you need to have a good grasp of the Fick equation. And obviously, it's been known for over 100 years. Cardiac output is equal to oxygen consumption divided by the AV content difference. If your cardiac output drops, you have to balance that equation somehow. Most patients cannot spontaneously alter their VO2 downwards if they're sick. So what they do is they increase the denominator. The only way to increase that denominator, you can't actually increase your arterial oxygen content to any great deal if your lungs are working normally, is to drop the mixed venous saturation. Okay, not rocket science. But what it does mean is we're used to thinking in linear terms. And what it does highlight is that the relationship between cardiac output and mixed venous saturation is non-linear because of that inverse relationship. And that relationship changes also depending on what your baseline is. So if you've got a higher VO2 to start off with, a given mixed venous saturation may mean something quite different. And if, more importantly, if you're starting it from a hypoxic point of view, and many of our patients are, they have ARDS or cardiac disease or whatever, the same mixed venous saturation has a different significance because the shape of this curve actually changes. The other thing is, if you're going to measure mixed venous or central venous, where do you measure it from? And I'm not sure how it functions in your unit, but the common septic patient has a raging coagulopathy. So when the fellow or the registrar goes out to resuscitate this patient, they'll tend to put a groin line in rather than a neckline. And you can see that there's a huge variation in venous saturations, and depending on what organ bed you're measuring. So unless you're actually above the liver in the IVC, you can't really be sure what you're measuring. Okay, kidneys. Their main job is to filter the blood. So they receive about a fifth to a quarter of the cardiac output. And as a consequence, they don't utilise a lot of that oxygen, so they're highly saturated. Gut is low. It can be a lot lower in sepsis. Liver's variable. Skin can be extremely variable, muscle and sepsis. So it's a real minefield. And the other point is, depending on where you're measuring, the proportion of flow between the upper and lower body changes with age. So you can see that in the neonate, on average, about 50% of the venous return comes from the SVC. And that rises on average till age 2 or 3 years to about 60%, and then there's a progressive fall off till about age of 6 or 7. You're more like your adult counterparts, and 30% of your flow is SVC related. So there's age-related differences, and you can see in healthy patients there's an enormous spread. So it's a trending parameter, but you must make sure that you measure it and that you know what site you're measuring it from. And the other thing is we're not so much measuring the adequacy of cardiac output, but it's the balance between oxygen delivery and consumption. Okay, normally delivery is well in excess of consumption. These factors here. And there's often a lot of mileage into actually manipulating consumption rather than manipulating delivery, because by the time you see these patients, most of this has been taken care of. They're fluid resuscitated, they're on inotropes, they're ventilated. To be honest, there's not a lot more you can actually do. There are proponents who say you shouldn't interpret the mixed fetus as an isolated figure, but you should interpret it in terms of the oxygen extraction ratio, or if you turn that factor on its head, it becomes the oxygen excess factor. And that's mathematically equivalent to the DO2-VO2 ratio. Okay. Normally, it's about 3 to 4. In certain illnesses, particularly cardiac diseases, there's a suggestion that you reach a critical threshold when you're below 2, and it's something that you can use in cyanose patients. Okay. So we ask our fellows to talk about either the arteriovenous difference, because that's something that most people can deal with. Ideally, I prefer the oxygen excess factor, but I can live with the difference. Okay. In cardiac surgery, how does the oxygen excess factor relate to the DO2 and VO2? And post-cardiac surgery, there's a tight correlation with oxygen delivery. So it tends to reflect delivery more than consumption. And that's because oxygen consumption is relatively constant post-cardiac surgery. So you can see this relationship's not great at all. It sort of peaks when you first come back and then settles down soon after. But what about sepsis? Well, we just don't know. There's not really the work out there. The other marker of inadequate flow is lactate. Traditionally the teaching is it's all to do with anaerobic metabolism. So you get a block here between pyruvate and acetyl-CoA, and you form lactate. And that's energy inefficient, and it comes with a cost, mainly the acidosis. Again, in sepsis, that's not necessarily the case. We now know that the most common cause of a high lactate in sepsis is catecholamine-driven, okay, and that's aerobic glycolysis. So it's linked to sodium potassium ATPase on muscle cells. Okay, excess catecholamines drive sodium potassium ATPase, and their main energy source comes from aerobic glycolysis, so this part of the chain. And that creates a bottleneck effect. So you actually saturate this part of the pyruvate to acetyl-CoA formation, and you form more lactate. Okay, and that's been shown in animal models, and then shown very beautifully in this group in France from Levy's group, where if you look at the mean lactate concentration of patients in the ICU, in the red line, and if you measure the lactate concentration from muscle dialysate, so these patients had a dialysis catheter put in, a microdialysis catheter put in their rectus muscle, you can see that the lactate is about 1.5 to 2 higher on average. If you then block sodium potassium ATPase, that lactate in the other muscle that you block it actually comes down to reflect serum levels. So it's not simple. And the other confounding factor is lactate is actually, we now know it's actually an intracellular, and intercellular messenger. So it shuffles between cells for a lot of other reasons as well. Base deficit, just very briefly, I couldn't give a talk on cardiac output without talking about base deficit. Just to put it in perspective of sepsis, this is a group of 80 children with meningococcal disease which are resuscitated from the time they arrive in the DGH. This is their base deficit with time. Okay, so it stays very, very elevated or negatively elevated for at least the first 16 to 20 hours. But if you break down that base deficit as to the cause, when they first arrive, it's mostly unmeasured anions, which by 4 to 8 hours are pretty much gone, and hyperkalemia takes over. Okay, so the perpetuation of the base deficit in sepsis is in this case is due to hyperkalemia. If you treat with albumin, you may actually negate the alkalizing effect of hypoalbuminemia, so you may make the base deficit worse. So interpret it with caution. And you can see that's directly related to how much chloride you receive in the first 8 hours, as to how much your chloride portion of your base deficit changes. So, finally, I get round to the point of the talk. When might we actually consider measuring cardiac output in sepsis? And these are a few, just of my own thoughts. This is not evidence-based. It's just sort of plucked off the top of my head, and I'd be quite interested in if anybody disagrees with this. Commonly, we see the patient, maybe they're hypotensive, they might have a narrow pulse pressure, you might have actually had the benefit of doing an echo and suggested poor cardiac function, or they may have a persisting metabolic acidosis. And you may want to measure cardiac output then. What are you asking? Well, which hemodynamic profile do they broadly fit into? So it may be just a quick and dirty look. You might not want a tool which is highly invasive and highly accurate. You may want a tool which is just gives you a ballpark figure but tracks changes adequately. So obviously this group, there may be a role for a vasoconstrictor. In this group, where both the cardiac output and the SVRI is low, you think about an inotrope. You may want to give some more fluid, and you may want to think about a constrictor. In the group with the low cardiac output, high SVR, the role for inodilator and perhaps some more fluid. Moving on, it's the patients with multi-organ failure or sepsis who have a significant ongoing volume, inotrope or vasopressor requirement. Okay, these patients may be adequately resuscitated, and what we are now doing may be doing them more harm than good. So really what you want to think about is how does the patient respond in the way of changes of forward flow when you give or change a therapy. Okay, first question, as we showed in the previous slide, are you over-vasoconstricting the patient? And is that adversely affecting the contractility in his stroke volume? So I've used that on a handful of patients where I've been on a very high dose of noradrenaline and adrenaline, and I've effectively halved it. And although the blood pressure has dropped, the cardiac output has gone up, so I think it's a reasonable price to pay. Does volume improve? Giving more fluid volume, does it actually improve the stroke volume? And if so, is this sustained? Are we over-distending the patient, or are we giving volume which is not staying in the intravascular space? So you might want to think about giving less volume to these patients, or perhaps an alternative type of volume replacement. And lastly, just to hark back to the idea of DO2, VO2, the inotropes that we use all have a major price in terms of increasing oxygen consumption, and that's mainly through thermogenesis, but there are other mechanisms, and there are also a lot of metabolic side effects, lactate production, disorders of lipids, potassium, the whole works. So by increasing the inotropes, are we actually decreasing VO2? Sorry, are we actually increasing oxygen consumption far more than we're actually increasing oxygen delivery? And again, if you're going to do that, ideally you want to think about measuring oxygen consumption. But the main thing is change your therapy and see how the patient goes. We're using some new agents in sepsis. I mean, levosimendan is something that's creeping in. It's certainly something we've started using in our unit. It's hellishly expensive. You don't want to throw it around like lolly water. So if you're going to use an agent, you want to know it works. And lastly, it's the group with suspected cardiopulmonary interaction, so the bad ARDS patients who are perhaps hypotensive. And again, continuing the same theme of withdrawing therapy rather than giving more, we may want to decrease the distending pressure of the ventilation. We may want to think about turning down the mean airway pressure. Or perhaps, if we can't do that because the lung disease is so bad, we may need to give more volume. So just to summarise, 3 things. What we haven't yet done is tested where the cardiac output measurement can actually provide benefit when it's incorporated into a sensible, and I stress sensible, goal-directed therapy algorithm. This may be more likely to occur when the tool for cardiac output measurement also includes measures of preload, contractility and afterload. And apologies for not being able to touch upon this today, but like I said, I will talk about this later on this afternoon. And this is starting to occur with many of the new tools that are coming through. But the potential downside here is that it may make the measurement and, more importantly, the interpretation of that measurement more complex. So I think it's a case of watch this space. Thank you.